We all know this history. We all work with community health workers one way or another, and we champion them. And we know they've been around since 1978, after the Alma Ata Declaration. But there was a decline in that. But the interest is coming back. I mean, it's been a major focus even at this symposium, discussing community health workers, other frontline workers, what can they do, and the different types. And their role has really been acknowledged due to different things that are happening. We know we have healthcare worker shortage, and it's a crisis, and especially in developing countries. And we've talked about it for the longest time, so this has come in as one of the solutions. We've seen community engagement in health systems is critical for achieving any impact or outcomes at the health, for our health system in general. And we know that the community health workers have been shown to have played a critical aspect in the emerging health system threats like Ebola that we've had and other fragile states issues. So we know they're important, but have we addressed that need of what do they want? How do we address their needs? How do we get them to engage? And in the same way of proving that community health worker programs work, the large-scale programs that have been done at country level, like in Brazil, Malawi, Nepal, Rwanda, have really shown that we can get good results from these groups. I just borrowed this slide to show a summary of who CHWs are from all our different contexts. And who they are, we know they vary. Some are, they're different in terms of their training. There's limited training, it's not formal, but the level of training varies. What they do also varies, but we know that one thing is that they all work outside the health facility. They're the ones in touch with their households, and they do different tasks. How they're paid or how they're categorized also varies. In some countries, they're recognized and given a cadre. They're actually a recognized cadre, which is in the scheme of service of the government. In other countries, they're not. In others, they're salaried. In others, they're not. So it's very varied, and we need to start thinking what works best for these groups. And where they work and what they do also varies greatly. And we know with the vertical programs, different new interventions come in, and they're expected to do that and also support the other primary healthcare tasks. So community health workers are important, and we've seen this from data and evidence from everywhere. And I got this quote from there was an investment case for financing community health workers, and it really talked, I thought this was very important, that while it may take decades to build enough health facilities to ensure that all rural and remote populations are within walking distance of clinics, CHWs connected to well-formed and managed primary healthcare teams can extend the reach of high-quality care to people who need it most, right where they are. And this is especially true for us in Kenya, where in the decentralized health system now, every county government wants to build more health facilities, put up more health centers that they will not staff, and yet they have this group that we know can provide services as we build the formal health system. But how do we invest in that? And you can see over there some of what they have been saying in terms of how important they are to the community and how they feel important, getting their voices heard about how they value and they feel valued when the community recognizes them. We know CHWs played a critical role during the Ebola outbreak. This is not in doubt, and we know it's no longer a question. But the question is, so what do we do with that information? How do we move to the next level? How do we shift that rhetoric from just saying they're good and they're useful to making their voice matter and what they do actually matter? This slide is a summary, also borrowed from a friend, of showing how effective community health worker programs are and what the evidence has shown from a quantitative perspective, and how they've had an impact on child health indicators, maternal health, HIV/AIDS, water and sanitation, and NCDs. Again, all the vertical programs we've been talking about and the primary healthcare outcomes that we are seeking, the evidence exists. They are useful. They are helping us achieve the impact that we seek. So what do we do next? The challenge remains. They're considered, in many cases, we have a community system and then we have the health system, and they're considered separate from that. And the CHWs themselves have perceptions, have ideas of what would make them feel better, how to be of value. And these are some of the issues that have come up from research that we have carried out. I'm part of the Reach Out Consortium, that is a 6-country data collection in 6 countries, but it's an 8-country study that has shown us, and we got some of this evidence from there, about the issues that the CHWs felt were affecting their performance or motivation. And lack of recognition and involvement in planning and decision making has come out clearly in many studies. There's lack of formal training and continuous professional development. In many cases, we find that even when the curriculum exists for, say, a 2-week or a 6-month training, there are many who have not gone through that basic training. And then supportive supervision came out very clearly, especially in our reach out study, as a gap, and that as supervision being a motivator for them that would help them do their work and really perform well. The issues of being paid, we all expect to be paid for our work, and yet we have this cadre that we're not paying. They have said it and they will always keep saying it. They're an overworked, under-supported cadre, and they are full-time. We expect them to be full-time volunteers. So what do we do differently? And then lack of basic supplies and equipment that they can work with have also come out very clearly from the CHWs themselves as something that we need to address in the programs.